Hello everyone. Today we are going to have a video on how to check preparedness of the operation theatre before doing any standard endoscopic surgery. Now all of you may be operating at your own center or may be operating at various other centers for doing a Gynaec endoscopy. But regardless of where you are going for doing surgery, it is important that you check that the OT is well equipped before you start surgery in order to avoid unnecessary delays and complications after starting the procedure. So what all do you actually check after going into the operation theatre? The first and foremost thing to check after entering the operation theatre is the patient's papers. What exactly do you check in the patient's papers? Of course, you will have seen these papers beforehand, you will have investigated, diagnosed the patient with the pathology, but after you enter into the operation theatre, one final checklist is required. The first and foremost thing to see after entering the operation theatre is the patient's consent. Has the consent been taken? Has the consent been informed to the patient? And has the consent been signed by the patient and by the relative? The second important thing to see is the patient's reports. Sometimes a patient may be unfit for surgery, which has slipped the attention of your staff or you because you were busy in your OPD earlier. So just go through the reports, go through the paper, go through the file and find out if there are any factors that make her a high risk patient for surgery, in which case you may have to defer the surgery or postpone it to a later date or cancel it completely. The third thing is the ultrasound reports. The ultrasound reports have to be seen to find out whether the surgery that you are intending to do is actually in tandem with the ultrasound reports that the patient is carrying. Meaning that sometimes the patient may be posted for a laparoscopic myomectomy and you may be carrying the impression that you are going to remove a small 2 or 3 centimeter fibroid, but when you actually scan the reports you find out that it is a very large 10 centimeter myoma and adequate OT precautions have to be taken accordingly. The fourth important thing to see after entering the OT is if you are planning a major surgery, has adequate blood been reserved or not. So with these basic preoperative precautions, we proceed to the next step. When you enter the OT and you are going to start surgery is whether the rest of the OT is prepared for an endoscopic surgery or not. The first thing that is of prime importance that you must see, especially if you are operating in an unknown setup or you are operating somewhere for the first time, is the OT table. Now, why is the OT table important? From a gynecology point of view, there are 3 or 4 very specific things that you require. The table, the ability to turn the table to the head low and the head high position. Capture the table also please. So the ability to turn the table to the head low or the head high position. The ability to tilt the table laterally. And lastly, rather most importantly I would say, can you please capture this, is the ability to change the position of the rods. For Gynaec endoscopic surgery, we require that the rods be in an extended. It is important that the OT table has a facility for giving extended lithotomy position. An extended lithotomy position means that during standard gynecological surgery, it suffices if the rod is straight or at right angles to the ground. However, this causes a problem that the leg is hyperflexed, and this hyperflexed leg makes it difficult for the side ports to be manipulated when the patient is lying in the lithotomy position. Other than that, if the OT table has a facility, and every OT table on which you are planning Gynaec endoscopy must have this facility, that you must be able to turn the stirrups to the desired angle so that the patient can be given what we call as an extended lithotomy position. In this extended lithotomy position, the patient's legs will rest at a level where her knee is parallel to the anterior abdominal wall, and the ports which are placed on the sides of the patient will not be hindrance in doing surgery. Stop. Lithotomy position. So, operating during an endoscopic surgery is the readiness of the anesthesia machine. One should always have a good anesthesia machine, particularly equipped with an NIBP machine. Nowadays, the gases which are used are generally, earlier we used to use nitrous oxide, but now sevofluorine and isofluorine are thought to be much safer. So when you come in, of course, the anesthetist will do the checking, but just confirm with the OT in charge sister that these gases or whatever are required for general anesthesia are adequate in quantity. Check that central oxygen supply is connected and check that you have a spare oxygen cylinder just in case you require it. Of course, it would be ideal to have an inbuilt ventilator setup so that it makes the surgery much more safer, and the other equipment for a difficult intubation. Another important point to look for in the NIBP machine is the presence of an EtCO2 probe and monitor, because we are going to be using carbon dioxide, we are going to insufflate carbon dioxide, which might result in the carbon dioxide level in the body going up, and an EtCO2 monitor which is there in the OT will help us to find out if the patient is having this CO2 toxicity, and to either stop the surgery or to withhold the surgery for some time if the patient is showing signs of hypercarbia. Check before starting your endoscopic surgery is the endoscopic trolley itself. Check that you have all equipments functioning, your monitor, camera, light source, CO2 insufflator and cautery, and other energy sources if you may require them, like a harmonic. Turn on each and every piece of equipment to find out if the equipment is working. Turn on your recording device, because many a times after starting the surgery you find that the recording device is not working. Lastly, but of course one of the most important things, please check that your CO2 cylinder is adequately full, because after starting surgery if you have to keep changing the cylinder, that is an unnecessary waste of time. Most of the newer CO2 machines are equipped with a sensor in which you will be able to find out that the CO2 is, whether the CO2 is adequate or not in quantity. If not, sometimes you have a dial which can be fixed on the CO2 cylinder itself to find out if the CO2 cylinder is empty. Check for standard laparoscopy instruments on the trolley. Other than your regular endoscopy equipment, you need to have certain instruments which are of open surgery or laparotomy. Particularly required instruments for a diagnostic hysterolaparoscopy are a pair of forceps, scissors, needle holders, 2 artery forceps, 2 Alice forceps, a set of dilators, 14 number blade, curette, sim speculum, and certain other instruments to clean the anterior abdominal wall, including disposables like gauze, cotton, sterile vatis for collection of either betadine solution or spirit, and certain disposables that you may require. These disposables specifically include sometimes a camera cover and a wide bore infusion set for doing hysteroscopy, which we usually prefer to use as a TURP set. Stop. Finally, when you take the endoscopy instruments on the trolley, needless to say that all endoscopy instruments need to be inspected before you actually start using them. But just some of them, for example, when you take the telescope in your hand, make sure that the telescope is working properly by holding it against the light and checking the image within the telescope, just to make out whether the lens is cracked at the proximal or distal end, which may have happened inadvertently during cleaning during the last case. Then your set of hand instruments, including your graspers and bipolar cauteries, assemble them and make sure that the instrument turns freely in your hand. Also make sure that opening and closing the instruments results in the jaw opening and closing properly, otherwise you will have to spend time doing this after the case is on. Particularly in the case of instruments that use electrical power like a bipolar or a monopolar instrument, make sure that the insulation over the sheath of the instrument is intact and that there are no kinks or exposed areas along the instrument from where the current may leak. Lastly, all trocars, hysteroscopy sheaths and any other devices having an inlet and an outlet mechanism, make sure that the inlet and outlet mechanism is working properly and that it is moving freely so as to allow the flow of gas or air or liquid, as the case may be, during surgery. After the patient has been brought into the OT, make sure you greet the patient, make her feel a little bit at ease. Take a moment again to reconfirm the identity of the patient, to reconfirm that the patient knows why she has been brought here and what surgery she is going to undergo, which will allay her fears to a great extent. Doing all these small and simple steps before starting your case will definitely make sure that you have a whole lot of safe Gynaec endoscopy coming your way. I wish you all a very happy new year. Thank you.